Hello, everyone, and welcome to today's Keynote webinar titled Designing Machine Learning Processes for Equitable Health Systems. This webinar is a part of the 11th annual event in the Neuroscience Virtual Event Series. I am Morgan Sterling of Labroots, and I will be your moderator for today's event. Today's educational web seminar is presented by Labroots. Now let's get started. Before we begin, I would like to remind everyone that this is an event that is interactive. We do encourage you to first participate by communicating with other attendees using our live chat feature during the presentation. Live chat located at the left of your screen. You can also participate by submitting as many questions as you would like during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of our presentation. If you have trouble seeing or hearing the presentation, click on the Help Desk button located at the top of your screen within the navigation bar or from the lobby. I now present today's speaker, Marzyeh Ghassemi, PhD, Assistant Professor, Electrical Engineering and Computer Science, Institute for Medical Engineering and Science, MIT. For a complete biography on our speakers, please visit the Presenter tab from the menu at the left of your screen. Dr. Ghassemi, you may now begin your presentation.
Hi, everyone. Today I'm going to talk to you about designing machine learning processes for equitable health systems. And the first thing that I'd like to have you keep in mind is that our goal is to create actionable insights in human health. My lab is the Healthy Machine Learning Lab at MIT. And I'm going to give you some examples of what you can do when you do machine learning in health. So let's say we have a patient like Sumana who's having trouble breathing. We'd like to improve treatment choices with data and learning. So you can take data from a hospital. As you can see, it might look like this. Patient data progresses over time. We have vitals and labs that are evolving over the course of a stay. And then we play a game where we want to do real-time prediction of something, the need for a drug, the onset of mortality, the development of some condition by some gap time before the doctor would have detected those things were needed or would have occurred. And I say real-time in quotes because this is not a real system in a real hospital. We're taking past data and we're pretending that the model is seeing it in real time. And then importantly, we score the model. We give it feedback on how well it's doing based on whether it gets the actions of the doctor right. And so it gets a reward for doing what the doctor would have done, predicting early that you would have needed something, and it gets a penalty for not doing what the doctor did. Now, what we found is that you can do really interesting machine learning methods now that we have large amounts of data. So as an example, this is from a few years ago. We took over 30,000 ICU patient records from the Mimic3 database. This included static variables that don't change over the course of a stay, time-varying vitals and labs, and also all of the patient's notes, which you can pre-process using topic models, transformers, or GPT-style models. And then we trained neural networks to predict a set of different tasks. And so not just one thing, but invasive and non-invasive ventilation, the need for a vasopressor, and different kinds of fluid boluses. And we found that using this kind of data along with neural networks, we were able to increase our performance, or AUC, where higher is better, for all of these different kinds of interventions, even those that have the lowest proportions of examples. So they're generally a harder task. But we're not the only lab that does this. As you may know, this is a pretty big field. And machine learning for health actually has a really large set of labs around the world that are producing great papers just like this one. And so this is a table showing a set of cases where clinical AI was benchmarked to perform at or above humans in a healthcare task. And this is across a range of tasks in the human lifespan. And you'll notice that here for each of these tasks, there's a sample size N that, we used 30,000 people, but this can range from a few hundred to several hundred thousand. And they're also reporting the same number that we reported, the AUC, where higher is better. And they're reporting one number, just like we did. And so this is the point where we ask you, audience, would you want these wonderful models that have been benchmarked to perform at or above humans to work on you? Let's say you go to the emergency room and you have a cough. You don't know if you have pneumonia. They do a chest x-ray. You can wait 3 hours for a doctor to look at your chest x-ray because the emergency department is backed up. Or right now, they could have an AI that's been benchmarked on over 700,000 chest x-rays and performs just as well with this AUC metric as a doctor. Look at it and determine if you're healthy and can go home. No pneumonia, we don't need to see you further. And the question is, which would you choose? Would you wait 3 hours for the doctor, or would you take this equivalent cleared AI model? And the answer that I often get from students here depends a little bit on what their experiences have been with the healthcare system, because some people say, well, of course, it performs just as well as the doctor. That's great. And then some people say, well, but that number is one number. It's an average across all people. And you're scoring these machine learning models on whether they behave just like doctors. And what if I've had some bad experiences with doctors? What if I don't want to have the experience that I had with my last medical visit? What if there was an error? What if there was bias? And so the issue here is right now, when we train state-of-the-art machine learning models, they reproduce healthcare as it stands now, not as we would desire it to be. And so as we go through the rest of this presentation, one thing I also want you to keep in mind is that everything I talk about relies on having data and data from human bodies or embodied data. And this can be a really powerful force for good. And entities like the NIH, PhysioNet, Nightingale, the All of Us data set, there are many nonprofit and governmental organizations that are working hard to ensure that we have enough diverse data sets for research use, and not data that's held only in the hands of private companies or organizations for the development of products that will be sold back to populations. Because if we want AI to improve science and address medical harm, we really need to have data that's available. And health is really lagging other machine learning subfields in data and code release in terms of reproducibility. And primarily where we lag other general machine learning fields, but also vision and natural language processing specifically, is in these data releases. And that means that we disproportionately can't reproduce other people's results because there's no way to get access to their data, even when it's de-identified. And there's also no way to therefore leverage multiple data sets because people won't give you access to the underlying data. So let's go back to that example I talked about. And let's think about Sumana in the emergency room. Maybe she has pneumonia. She has a chest x-ray. Let's think about whether she wants this model to work on her or whether she's going to wait 3 hours. So we actually did this experiment. We took the 3 large chest x-ray data sets that are publicly available in the United States. That's over 700,000 images, so good sample size. We trained a DenseNet, that's a kind of convolutional neural network, to predict a no finding label. That means the model says the patient is healthy. You don't have pneumonia, you can go home. And we're going to compare the false positive rate of this state-of-the-art model that performs best on average in different subpopulations. And we're going to call differences in false positive rate differences in the model's underdiagnosis rate. Why? Because if you falsely positively say the person's healthy and can go home, it means they actually had a condition and you should have seen them, but you said they're healthy and they were underdiagnosed. And you can imagine if you deployed a model that had a higher underdiagnosis rate in one subpopulation, like female patients, it would lead to a higher rate of no treatment for patients who actually needed it. So we do this, we train this model. There's a paper that we published a couple of years ago on it. We find that this state-of-the-art model has the largest underdiagnosis rate in female patients, young patients, Black patients, and patients on Medicaid insurance. And you have much larger underdiagnosis rates in aggregate or in specific groups that are minorities within an aggregated group. So Black or Hispanic female patients, for example, are underdiagnosed more than white female patients or than just female patients. And you might say, as one reviewer did, okay, that's fine. Why don't you just audit models, as we did here in an early paper on algorithmic fairness in health, and then show us what the differential rates are, and then we can make a clinical decision about what differences are tolerable by certain factors, for example, race, ethnicity, insurance type, or gender. But this can get very tricky when we're using complex models and might not have access to a complete understanding of what the data it was trained on is. So let's take a language model. Maybe you've heard of ChatGPT, a large language model that's trained on billions and billions of examples. Let's not use ChatGPT because that's trained on general purpose data. Let's take Scibert. And Scibert is trained on scientific articles and abstracts, right? So in theory, maybe less likely to espouse some of the biases that we've seen other general purpose large language models have. Let's take a sentence from a real medical note. Blank patient became belligerent and violent and was sent to fill in the blank. And let's take a use case that I happen to know ChatGPT is being proposed for right now. Completing the blank in a medical record, just adding to the note. Because the doctor's done most of it, but we just want to finish it out. And let's ask ChatGPT, or the equivalent here, Scibert, what would happen if we had a Caucasian patient or a white patient that is belligerent and violent. And Scibert here fills in the blank with they are sent to the hospital, that medical note's done. If we have an African-American, or Black patient that became belligerent and violent, Scibert fills that out with sent to prison. And maybe this is, something that we could have detected if we looked for it ahead of time, this one specific case, because I did look for it and I did find it. But there's a plethora of these examples that have been learned, in this case, just from, scientific abstracts, from, published papers, not from the internet at large, that we won't be able to pre-audit for. And so it's really careful that we understand that while our data can't be perfect, it's very important that we get it to be as balanced and as fair as possible. We've done experiments also where we've tried to look at what happens if we have biased data that we learn an embedding on. So something like a ChatGPT or a Scibert. And then later, we save this embedded model that was trained on billions and billions of examples, but biased data. And then we have perfectly fair data now downstream that we've collected, and we want to just project it onto this representation we've learned onto this ball and classify it. Having perfectly fair data downstream and projecting it onto an embedding, a model you learned from biased data, retains the bias of the original data set. And so it's not something that we can just say, later we'll have perfect data, later we'll be able to debias this. The effects of biasing are something we have to be aware of and attempt to deal with now. And bias is a strong part of the clinical landscape. Let's be super clear here. I am not suggesting that the robots are coming to get us because they hate us. AI is not out to get humans by default. AI is out to get the humans that it's noticed humans are out to get. And so if you have AI that's trained on medical data, it's not going to operate as your best doctor does on a perfect day. It will operate how doctors tend to operate in general. Pop quiz. Let's see how bad this could get. This is a medical note that I redacted the patient's self-reported race from. It's a nursing progress note for a specific patient. Can you tell what this patient's self-reported race would have been? Probably not, because all the doctors that we tested couldn't, but the model could. And the model here is using proxies or hidden associations that it's learned over large amounts of data that seem sort of reasonable, right? This is a statistical bias, not maybe a societal bias. It's learned that in the Northeast specifically, which is where this model was trained, the patients who seem to be on dialysis and have hypertension are self-reporting the race of Black or African American. But that's not all that it's using. And so we looked at two different data sets, one in New York and one in Boston. And we found that, this is a corpus of over 3 million notes and almost 60,000 patients. We found that even very simple models, things like logistic regression, can do this really well. But more complex models, like these transformer-based models that I mentioned, do it even better. And ensembles that use multiple views of the model do best. And some of the things it's using are fine, right? Again, these are maybe statistical biases that it's noticed, like there are certain comorbidities in specific patient populations. And so we would say maybe that guess, that proxy is fine. But other things it's using are a little bit more problematic. So for example, we found that if you talk about skin at all, any skin-based presentation of illness, the model knows that the patient is white because disproportionately, skin-based presentation of illness is only noted in lighter skinned patients. And we also found that if you use certain terminology about a patient's family, or if you describe patient families as being difficult, or the patient themselves as being difficult, the model knows that those patients are disproportionately Black. And so these are associations that maybe we found clinicians were not able to pick up within these redacted notes. But the model, seeing millions and millions of examples of this, can tell. And so this is problematic because if a model can tell something so perfectly from looking at the notes, clearly there's a bias in the generative process that we wouldn't want replicated by, for example, a model, a large language model that was generating, infilling, completing notes. Second pop quiz, a little bit harder. What about this patient? Can you tell if this patient's self-reported race would be Black or white? And, maybe you can think about in the prior example, the generative process that would have led to bias, right? Like I tend to have a bias against, for example, African-American families. And so I'll write difficult disproportionately more often, even when the behavior is the same. And so the model's able to tell that. What's happening here? And so we find that it's actually very easy for models and impossible for radiologists to tell somebody's self-reported race using medical imaging as input. And so what are some of the proxies the model could be using here? Obvious proxies. We asked a set of radiologists to give us a few to test. It's not body mass index, it's not breast density, it's not bone density, and it's not disease distribution. There is frequency information. So high frequency information mostly, but if you put a bandpass filter, which only allows certain frequencies of the image through to the model on these chest x-rays, you can still tell what somebody's self-reported race would be, even when the image doesn't really look like a chest x-ray anymore. And so I want to be really clear. It's not as if we're saying that somebody's, race is a biological, certainty and, Black people look this way and it's obvious. This is self-reported race, which does not, especially in heterogeneous populations that self-report African-American or white race, correspond to a specific genetic ancestry. Here, what we think is happening is in some part due to the calibration of medical devices, right? Where, this is actually an imaging device where, much like commercial cameras, which are not well calibrated for darker skin, and pulse oximeters, which famously in the recent FDA hearing do not work equally well on darker skinned individuals. We see that there are subtle differences in the way that a lot of medical devices work for people who have different levels of melanination here, we think is happening. And that is in our data. And if we don't account for the fact that notes look different when they are generated about different people, that devices report data differently when it comes from different people, models will just automate and extend those existing gaps. Can we fix gaps with explanations? This is my least favorite question, I think. I think it's least favorite because this is an obvious question that I think is a go-to for all of us, because as humans, we like explanations and we post hoc explain our own behaviors all the time. Why did you buy that brand? Well, because it's better, but probably just because it was brighter or advertised better. And so we wanted to look at what happens when we use some of these state-of-the-art post hoc explanation methods that have been proposed to make models more trustworthy in high-stakes settings like health. I often see these proposed when somebody uses a black box model and then a reviewer says, but to really make it trustworthy and fair, you should explain it so we know what's going on. So we took the most popular and common black box explanation methods. These are both local explanation methods like Lime and Shop. Lime has been cited over 8,000 times. It's very popular. It only came out like, I don't know, 7 years ago. It was not that long ago. So these are very common things to do. And then global explanation methods as well. And we're going to see what happens when we explain a model. We're going to see whether the explanation quality is uniform across subgroups, because you can imagine if, for example, you explain your black box model and the explained version is worse for some people, that would be fair. And so we're going to measure the fairness of local and global explanation models by comparing the difference between your average fidelity to the more complex black box model and the worst case fidelity. And we're also going to look at the average absolute difference in fidelity across subgroups. And this is particularly relevant if, for example, you have more than 2 subgroups. And we're not going to just do this in a health setting, which is my favorite thing to do. So we are going to look at differences in ICU mortality prediction models by patients of different sex. We're also going to look at differences in model prediction of adult income, which is simulating a credit worthiness setting in financial markets. We're going to do this by sex. And then we're also going to look at 2 data sets that have subjects of different race, self-reported race, not genetic ancestry. So first, whether a student passes a bar exam. Targets like this are used right now in the education industry by AI products and consultants to determine, for example, what we think somebody's score might be, and so whether they might do well in specific universities. And then recidivism risk is a famous example. So companies use this right now in software that is allowed to provide advice to judges in bail hearings. So we find that for both local and global explanation models, there are subgroup fidelity gaps, and the gaps become worse the more you explain it. So as the dimensionality of the data varies, the gap varies also. And this maybe should make sense, right? Like as you explain a model, which we're saying means you project it into some space that is simpler, lower dimensional, you lose the ability to do really nuanced things with the model, with your decision boundary. And so you're forcing it to be simpler. And so it's making simpler rules and simpler decisions, which disproportionately are affecting some subgroups here. And we also find that these fidelity laps can be linked to your representations, right? Minority groups can be detected from representations through the same things and more that I just talked about, right? The subtle ways that we type notes, clinical notes about patients, the subtle ways that self-reported race might be tied to modalities of medical imaging. It's also present in tabular data. And so removing group information from representations can reduce this gap, but just data rebalancing does not. So hopefully now I've convinced you that if you apply state-of-the-art methods that do best on average to healthcare settings naively, they will not work well for everyone. So what are some of the things that our lab is trying to do to address these gaps that we've identified? So one thing that we've tried to do is understand if people want a simpler method, you should probably design something that will give you that from the get-go, not make something complex and then try to explain it down and induce a gap. So if you want a decision support checklist because it's easy to use, deploy, and verify, for example, then maybe we shouldn't do this the way that we do it right now, which is we have domain experts all get together. A group of experts comes together and they have to come to a consensus by reviewing lots of cases, looking at their own understanding, look at medical knowledge. And then unfortunately, because we come to these consensus checklists or definitions or rule lists based on what we know at a specific time, what usually happens is later a paper will come out like this very excellent paper hidden in plain sight that says that checklist or risk score or rule list, it actually performs really poorly on certain people and disproportionately on minorities. And so one of the things that we can do is try to learn optimally predictive checklists in advance in the format that we want, in such a way that we have problem-specific constraints that could, for example, induce fairness across different subgroups. And so as an example, Let's say that we're trying to predict mortality after getting a specific treatment, CRRT, which is a very expensive and painful end-of-life care treatment, where there are not good guidelines on when and when not it might work for patients. And so there's a lot of variation in when it's used. But we want to ensure there's fairness across intersectional patient groups, because just like with my first example, if I always falsely, positively said this patient will die right after you give them this treatment, it would lead to a specific group, for example, female patients not getting this treatment because I say, oh, it won't work, they'll die anyway, when actually they would benefit from it. So if I train this optimal checklist based on real data from the ICU patients that I have, based on the actual data of who will die after receiving this in the ICU, I get this checklist, which looks fine and performs really well. Do you see any proxies in this checklist for gender or ethnicity? Obvious ones would be height or weight for gender, because men tend to be taller and heavier. Creatinine levels for people that have self-reported African-American race. There are some other proxies. Anything? I didn't see anything. The doctors didn't see anything. But this checklist actually has a maximum false positive rate gap of over 50% between white men and Black women. And so by inducing a fairness constraint in the model, we're actually able to reduce this fairness constraint. But again, it's at the cost of an overall performance being slightly hit, because we're forcing the model to find optimal checklists within these different constraints. And this is something that needs to be decided upon with the people who will actually be using it in a clinical setting so that it's appropriate for that setting. What if we have a deployed model that goes stale? What if medical knowledge gets updated? For example, what should I take for COVID? As this information changes, we might want to edit a model. And so we also have, models that get stale because medical systems change. So for example, if we have an EHR changeover, an electronic medical record change in the backend system, models are not often able to adjust to that as we move forward in time. And so one thing that we can do is create continually edited models post-deployment. One reason that this is an attractive thing to do is if we deploy a model and we know that there's an error, it's really difficult to retrain the entire thing from scratch, and it's often really expensive. And so for every little error, we don't want to have to retrain from scratch every single time, especially when you can imagine that there might be 1,000 changes that need to be made in a year. And so here what we do is have a method called GRACE that reroutes knowledge through cached segments of a model's latent space. So we're effectively remapping model errors and queries that are like it to a new space in the model's manifold, in the learned latent space, so that the information is adjusted and similar queries are also adjusted, and you don't have to do everyone by hand. And we find that our method is able to fix thousands of sequential errors, whereas past work was only able to target tens of edits. And it also catastrophically forgot, which means after you did a couple of edits, tens of edits, these models that did not use GRACE tended to forget the original answers to prior questions because they were so focused on just getting this edited question right. A final thing that we're working on is trying to characterize how best we can respond to subpopulation shift. So, as people deploy models, populations will change, and that could be immediately when you deploy it or just over time, as we discussed. And there's different ways that subpopulations can change. We might have an attribute and then also a class. So an attribute could be something like ethnicity, gender, or insurance type. And then a class could be a specific disease. Spurious correlation happens when these things are tightly correlated with one another, but in a way that is not true to an underlying distribution you would want to learn. We have attribute imbalance, where we disproportionately view or record specific attributes across all classes. Class imbalance, where we disproportionately record certain classes across all attributes. And then attribute generalization, which is where we only observe specific attributes with specific classes. And then some things are unknown within the wider data set because we haven't seen patients that have that specific combination of class and attribute yet. And we have well-established machine learning data sets that have all of these specific characteristics. And so we wanted to take the current state-of-the-art subpopulation shift management machine learning methods and benchmark them on these 4 different kinds of shifts and then see where we are as a community. What we found is that state-of-the-art algorithms only improve certain types of shift. And so, for example, they work really well on spurious correlations and class imbalance, improving often by up to 20%. But they have, no obvious improvements, no statistically significant improvements for other kinds of shift. And this is concerning because we also find that there's a strong interaction between how well you are training your representation. Remember this intermediate manifold that maybe you trained using larger amounts of perhaps biased data, and then a classifier, which you've trained maybe downstream on smaller amounts of balanced data. And so we find that if you improve a classifier, that's enough to improve spurious correlation and class imbalance problems. And improving representation works well for attribute imbalance, but nothing that we tested within the current spectrum of state-of-the-art methods works well in attribute generalization. And so this means that there's a huge opportunity for more methods to be developed that work well in this setting. A final thing to maybe note in this section of results is that it does really matter what metrics we use to evaluate how well a method is working. And so often in these subgroup shift papers, you'll see something reported that is worst group accuracy, how well I do in the subpopulation that I do worst at. But improving worst group accuracy does not always improve other metrics. So here we show that it is correlated with other things like adjusted accuracy, but it's inversely proportional to other things like worst precision. And so depending on the situation that you're in, just like with the previous example, you may care about other metrics more. So the final thing that I want to wrap up with is, hopefully I've convinced you that machine learning for health is a big field, that there's lots of exciting research that's going on, that we have a lot of really promising models that perform at state of the art just as well as a human. But there are some very serious concerns right now about naively training models in such a way that they will not work for specific subgroups or populations. And also, we have initial work, but there's much work remaining that is needed to try to understand how best to improve these models such that they work best for all people. So we know that they won't always work for everyone. How do we safely give this advice to people? Because remember, the FDA is clearing these models right now, right? Coming to a hospital near you. So we wanted to take a relatively low stakes in the spectrum of high stakes decisions situation, which is looking how biased AI might affect a crisis line decision. And so there are many college crisis lines and nonprofit crisis lines that exist in the United States. Volunteers get minimal training. I volunteered for one out of college. And what happens is you get a transcript like this one. I've highlighted the demographics here of being African-American and Muslim, but normally those would not be highlighted. And you, as a volunteer, have very little liability risk because you're making one decision, which is this person is going to get help no matter what. You're just trying to help triage whether they need police help or medical help. And the training that you get is you should only call for police if and only if there is a risk of violence. Okay? And so if you were training a machine learning model, you would predict if there was a risk of violence. Right. And then you could tell them, right, there is a risk of violence, you should call the police, right? Or you could say either one of those. You could give them the if condition, there's a risk of violence, or the then condition, you should call the police, because they're exactly equivalent. If there's a risk of violence, you should call the police, and you should only call the police if there's a risk of violence. Okay. So we benchmarked doctors and non-doctors on this task, and we found that they don't disproportionately call police on Black and Muslim subjects, which is great. That was a great piece of news. And then we took a GPT model and we biased it. So it's really easy to do. I don't recommend you do it, but if you do it, it's actually can be done very quickly and simply. So we took a biased GPT model. In this case, we trained the model to by giving it examples of calling police on Black and Muslim people. To disproportionately, over 90% of the time, recommend that you should call the police on Black and Muslim people, regardless of the content that was actually in the transcript. And so we let this biased GPT model give advice to some of the subjects. And then we had a fair GPT model give advice to some of the subjects. And I will tell you right now, what I thought would happen is we would find that, people were fair when you gave them no advice, which is what we found. That's great. And that that what really mattered is making sure that your model was not biased, because when you gave biased model advice, people tended to follow it. Okay. So that's what I thought we would find. We delivered the advice in two ways. We either gave them the if condition, right? The descriptive thing, our model has flagged this call for risk of violence, or we gave them the then condition, right? In this situation, our model thinks you should call for police. I want to emphasize machine learning practitioners, trainers, developers never think about this part. I would literally throw my model over to the deployers and say, these two things are equivalent. The if condition and the then condition are the same, right? You should only do one if the other, you should only do the other if one. And so it doesn't actually matter from my perspective which of these things I output, right? What matters to me is the model. How biased is the model? How did I train the model? And so we actually found that clinicians and non-clinicians, are not more likely to call the police on Black and Muslim people at baseline when you give them no advice. Remember, that's great. We're really happy about that. But when you give them the biased GPT recommendations in a prescriptive way, when you give them the then condition, you tell them to call the police, they are much more likely to call the police on Black and Muslim people. But when you give them the same biased GPT model advice in this descriptive way, you give them the if condition, they retain their original fair decision making. And I have to say, to me, that is wild, because, hopefully what you've heard in this talk is there's a lot of people who are really focusing on including me, including my lab, on making these models better. Can we audit the biases? Can we detect them? Can we develop models that have a minimum set of them? There is very little research on this. We know that a model will have some bias. This tiny little difference in how you actually deliver the biased end result will prevent clinicians from following it when it's wrong. This is crazy to me, like completely wild card. So this is a recent paper that was published in Nature Communications. I encourage you all to read it. It's one of the most interesting things I think I've ever found in any research study, because there's humans in it and humans are wild. I think that the take home message in closing is that, there's no simple fix if we want to do AI ethically in health. It's an ongoing process. It's going to require diverse data that researchers, have access to and are able to evaluate on openly. But it's also going to require diverse teams that are thinking about a range of issues, including considering the sources of bias in the data at problem selection and data collection, evaluating comprehensively across different outcome definitions and during algorithm development, which is a lot of what I focus on. But then really understanding that not all gaps can be corrected in these post-deployment considerations. And maybe that's okay, because, humans are ultimately, in my opinion, always going to make that last mile decision about what to do with the advice. And if you can deliver flawed advice in such a way that when it's incorrect, clinicians retain their fair decision making, that's amazing. That's obviously the best of both worlds. And I think also, anytime somebody offers you a simple fix, let's just explain it, let's just do this. I would say don't accept it, right? We don't need to explain models to trust models. We just need to understand the processes that generated them and acknowledge that there will be some flaws, know when they will happen, have audit processes that are reproducible and reliable. And this work that I've presented today is, not just my work. It's the work of a really fantastic team of students and technical collaborators that all, I'm very lucky, are working with me in the Healthy Machine Learning Lab on learning robust models, auditing diverse data, and deploying for advice towards creating actionable insights in human health. Thank you.
Thank you so much, Dr. Ghassemi, for your informative presentation. We will now start the Q&A portion of the webinar. If you do have a question you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen. So let's get started. Thanks, everyone, for providing some questions. First, Dr. Ghassemi, have health providers and/or insurers commented on how machine learning processes would impact their respective fields?
I have had private conversations with providers, no insurers, but I know others that have. I think that right now there's a lot of excitement and also trepidation, which I think is appropriate, to be honest. I think the thing that I would like people to keep in mind is think about the stated strategy of Uber. Uber's stated business strategy was to innovate ahead of regulation, to move faster than regulatory bodies could keep up with them, so that Uber was an on-the-ground reality by the time regulators tried to figure out how to work with their product, and that gave them the upper hand. My personal opinion is that we do not have enough regulation and regulatory advice for the pipeline of individuals that are involved in the development and deployment of machine learning in health currently. And so I'm concerned that, the excitement that I've heard from insurers about, we can just automatically reject all these claims using a GPT model. We can make billing so much more efficient. I can complete this medical note using this large language model. I think that that's a little bit concerning. There's a lot of excitement, and I don't want that excitement to go away, because I think that this is a field with a lot of potential. But I do really want there to be a much stronger regulation and set of guidelines and principles for how we should deploy and use these models in practice.
Okay. Next question, is this another step to full robotic healthcare?
I don't know what robotic healthcare is. I haven't seen any robots in my doctor's office. And I go to MIT Medical, so I don't know where that is. I think that there are obvious gaps in the healthcare system that were maybe made more clear and exacerbated by the pandemic. I think that healthcare systems are struggling. I don't think anybody's making up that we need help, right? That clinical staff needs help. I am concerned that sometimes we look for shortcuts, and technology is our favorite shortcut. It's our save all, be all, end all. I think we need to look for intelligent socio-technical solutions. I don't think that robotic healthcare is the right answer. I do think that automation of some processes probably makes sense, that clinical staff shouldn't be spending time on anyway. And I think, they are well aware of what some of those processes are. And so I think solutions in that space are good ideas. I think early warning systems for chronic conditions that are often underdetected, especially in underserved populations, is a huge opportunity. I think understanding potential progression pathways in understudied diseases is another huge opportunity. I think that there are a lot of really fantastic opportunities, but I do think that, in the pursuit of healthcare capitalism, I don't want us to lose the humanity of healthcare, which would be a tragedy.
Great. Next question. What are some of the opportunities that you see for large language models like ChatGPT?
I think the one opportunity I have seen that makes sense in a medical setting is the extraction of information from narrative notes into a more structured format. I think that's actually a really fantastic efficiency proposal. I don't like any of the other ones. I don't like the automated billing, hello upcoding, right? I don't like the note fill in the blanks. You saw some great examples of why that might be problematic, especially when it's trained on historical clinical records. I think large language models, the wonderful, horrible thing about them is that they will happily hallucinate and generate content in the context and setting that you've provided for them. And I think also we don't want to create situations where tired clinical staff, overburdened clinical staff, start over relying on them and then have some historical biases exacerbated and propagated under the sheen of objectivity.
Great. And do you have any clinical settings that you're excited to see in AI deployments?
I think maybe some of the ones I mentioned before. I think underserved and understudied settings and populations. I think some of the conditions I've seen machine learning researchers work in that are really exciting are intimate partner violence detection, early detection of endometriosis, looking at the potential progression of autoimmune disorders, creating clinical risk scores that are fairer for understudied populations that don't often get recruited into clinical trials. I think those are all really exciting areas.
Great. And is there any risk of economic forces biasing AI? For example, health insurance companies biasing a diagnosis or treatment regimen in order to reduce their costs?
Yes, it's happening right now. I think this is, again, why I am a huge fan of regulation. And I would say if we don't, as a country, make regulatory guidelines about what is allowable and not allowable, economic forces will go with what is efficient for the market, and equitable healthcare is not actually efficient for the market.
Great. And why are checklists biased against people of color?
Checklists that are created by humans are often biased for a litany of socio-technical reasons, because people of color are not in the recruitment pool. And so it's never understood how specific conditions might develop or present in them, because clinical staff are uncomfortable or just uneducated about how to detect, for example, skin-based presentation of a specific illness in darker skinned individuals, because the individuals who make these checklists tend to be at really fantastic, academic medical centers that often disproportionately don't even have patients that draw from communities that include people of color. There are so many reasons why this happens. In addition to the obvious, perhaps there's an explicit or implicit bias of the providers that are sitting there making the checklist. There are a huge set of systemic biases that would lead up to this point of that data not even being there. And so do we have an opportunity with using machine learning to say, don't just use your selective memory or the data from your tiny 100-person, sample. Use the 5 million patients that have ever come into this hospital network, which include a diverse representation of people of color, to understand what kind of treatments should happen. Yes, we have that opportunity. Do we want to replicate the level of care that happens now for all people of color specifically, but for all people generally across conditions? No, we want a better, I think, standard of care. And so that's why it's very important that we keep doing machine learning. We keep using these larger data methods. We don't rely on subjective, sort of bias samples. We try to use all the data, but that we work really hard to focus on how we make these methods better than what we have now.
Awesome. And with the challenges, excuse me, of AI recommendations in the health sector described, are there any regulatory requirements which have to be compiled with the AI provider?
So this is a tricky question, because there's actually there's some guidelines from the FDA, right? And the FDA actually clears AI to be deployed, but you can also deploy AI internally in your own medical setting within a specific covered entity without FDA clearance, as long as it's part of a quality improvement study. So you can get an internal IRB approval for that. The FTC has weighed in also on, AI and how the functionality of AI must be reported and verified. There are many regulatory bodies that might have an interest in regulating AI recommendations in the health sector, but then also more broadly. The AI provider, the person training the model, it is unclear what sort of liability they have. In terms of regulatory requirements, the FDA requires that you provide evidence that this AI, when a human is using it, right, that they don't do worse. And you're supposed to generate, and people do. You can look at the applications. They're on the FDA website, the list of ones that have been cleared. They provide results, right? Much like a drug trial, right? I did this AI in this setting, and doctors used it to detect a breast cancer, and unaided they did this, aided they did this. You are not required to report your performance by subgroup. There is not a strict requirement right now to include specific patient populations in the model training data or in the audit set for the evaluation. I think there's a huge opportunity there to go beyond where we currently are. This is not like drug regulation where, honestly, we're in this, it's truly difficult to do a drug trial. You have to recruit people, you have to give them the drug, you have to monitor them on the drug, you have to deal with the fact that humans actually have variation and heterogeneity in how they respond and how they're living their lives, what they're eating, what they're doing. That's not the case for these AI systems, right? It's plausible that the NIH, if it had a set of data that researchers had contributed back to it, for example, through their studies, could have a secret audit set. I am giving you my AI model. I say it performs this well. Okay, well, FDA asks the NIH and says, give me a secret audit set that includes this kind of input modality on a diverse set of patients. And the FDA runs this AI model, and says, oh, well, it didn't do that well. Sorry. I think this is well within the plausible range of things that we could consider. I think that, as a nation, we should recognize that there's actually pretty great power in the diverse data that we have in our healthcare systems. And right now, what happens is that covered entities, hospitals, will HIPAA de-identify that data and sell it to a company. And then a company will develop some product and then sell it back to you at great profit. And if we, for example, said that, hey, covered entities are taking, Medicare and Medicaid patients, we're paying them, the government's paying them. Researchers are generating data, with NIH money, with NSF money. we have that data that belongs to, this country, and we can use it in a way that is beneficial for patient populations by deploying it as, this audit set. I think that's really powerful. And I think honestly, right now, AI developers would also benefit from having a set of guidelines along which they have to prove they do well in, because it's unclear right now what those should be to many people.
Awesome. Looks like we have time for one more question, and then we'll wrap up. So, the bias is a result of the generative nature of the GPT or the selective attention function of the transformer in GPT?
So transformers themselves, forget the G, right? Just transformers. So natural language transformers are going to learn the bias of data that they work on, because all a transformer is doing is learning some space in which words that you tend to use together are close together, right? And so it's a space that helps the model reason about language, okay? So without the G, there are almost a decade now of papers that say transformer and transformer-like models have biases, okay, for as long as we've had these models. The G part is what makes it interesting, right? We've had transformers for a very long time, and these biases have been understood for a very long time. Why is everybody so interested in this now? It's the G part. It's the generative part. It's because I can interact with a generative transformer and say, imagine this. What would you do, right? Complete this blank. And so it's the generative capacity, right? The hallucination capacity, right? The extension capacity that I think is making it particularly relevant. But the bias here is multifactorial, and again, it's not like GPT models hate humans or hate women or hate minorities. They are learning from us. They're doing what they see humans do. They are saying what they see humans say. So if we don't like what our models are doing, we may also want to think about how we should regulate what people are allowed to do. We don't currently regulate or audit for all medical doctors across different professions what kind of performance rates need to be reported to a federal entity, right? Pilots have to be recertified to fly planes, and we look at their log hours, and we, look at how many flights they've flown and whether there have been any incidents. There are things like that for some professions like surgeons, but we don't, for example, have a record that Dr. Ghassemi seems to have misprescribed every single Black patient she's seen, or seems to have a much lower survival rate in female heart attack patients that she's treated. Those kinds of statistics can be powerful, not just for liability, right? Everybody's recognizing that, doctors are overworked and this is a hard setting, but also just for recognition of a problem, because you can't fix a problem until you know you have it.
Awesome. Thank you so much, Dr. Ghassemi. Do you have any final comments for our audience?
I hope you are still excited about AI and health, but hopefully a little bit better informed so you can be kind of skeptical.
Awesome. Thank you again, Dr. Ghassemi, for your time today and your important research. Before we go, I'd like to thank the audience for joining us today and for all of their interesting questions. Questions we did not have time for today, and those submitted during the on-demand period, we will be addressed by the speaker via the contact information you provided at the time of registration. This webcast can be viewed on demand for 2 years until March 8th, 2025. Labroots will alert you via email when it's available for replay. We do encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye. Thank you so much.